Hello, everyone, and welcome to our second in the series of our The Heart of the Matter webinar. We're just going to wait a few more minutes and let a few people, it's just 1 o'clock now. We're expecting some more people, so we'll just give them a few more minutes to log in. But thanks very much for joining us. Good afternoon, everyone. I'm Elizabeth Heald, Chair of Kawasaki Disease Canada, and I'm delighted to kick off the second of 4 sessions in our new webinar series, The Heart of the Matter. Before we get started, I'd like to share a few housekeeping items with you. You will see at the bottom of the page, if you hover your mouse, that there is a Q&A tab. Please use this to type any questions you may have for our panelists, and we will attempt to get to all the questions today. We are recording this session and it will be available later on our YouTube channel. We will follow up with a link sent to you in the next few days. We at Kawasaki Disease Canada are grateful for the many families all across Canada and beyond that help to share our messages. We are also grateful for the many healthcare professionals who support us and our mission towards enhanced awareness, education, support, and of course, research to help find a cause. I'm so pleased today to have 2 renowned pediatric cardiologists join us today to discuss topics covering general and public education, education for families and patients of Kawasaki disease, and education of healthcare professionals. First, I'd like to welcome Dr. Brian McCrindle. Dr. McCrindle is a staff cardiologist, section head of preventative cardiology, a senior scientist at the Hospital for Sick Children, and a professor of pediatrics for University of Toronto. I'm just going to we're having a little glitch with the video at our end. So I am just going to make Dr. McCrindle host so he can join me on the video. For more than 25 years, Dr. McCrindle has been caring for patients with Kawasaki disease, contributing to research and guiding policy. He has been the co-chair of the International Kawasaki Disease Symposium and was the lead author for the most recent American Heart Association Kawasaki Disease Guidelines. As I mentioned earlier, he also chairs the International Kawasaki Disease Registry, which has recently received funding from the NIH. He is also a principal investigator with the NIH Pediatric Heart Network, for which one of the studies is currently determining cardiac outcomes for children who have had the multi-system inflammatory syndrome associated with the SARS-CoV-2 infection. I would be remiss if I didn't also mention Dr. McCrindle's participation in the 2019 Scotiabank Toronto Waterfront Marathon. His efforts and dedication raised thousands of dollars for Kawasaki Disease Canada. We are so very thrilled that Dr. McCrindle now sits on Kawasaki Disease Canada's Advisory Council since our onset. So welcome, Thanks very much for joining us, Dr. McCrindle.
Thank you.
I'm now going to introduce Dr. Nagib Dahdah, and I might have to, I am going to make Dr. McCrindle is going to make Dr. Dahdah host if you can. And if my picture goes away, your pictures are much more important. So Dr. Dahdah is a pediatric cardiologist and professor of pediatrics at the University of Montreal. Dr. Dahdah has a track record in Kawasaki disease research and is a renowned worldwide expert in the field. He is also the co-founder of the International Kawasaki Disease Registry, the IKDR. This initiative started as a bipartite collaboration with Dr. Brian McCrindle, then became a North American collaborative effort, the North American Kawasaki Disease Registry, the NAKDR, associating researchers and clinicians from more than 30 North American medical institutions. Today, the IKDR collaboration spans from North America to South America, Europe, and Asia. The IKDR members represent now nearly 70 medical institutions and universities from around the globe. I'll leave additional detail on IKDR to either of our doctors later in the session. Dr. Dahdah has been involved with Kawasaki Disease Canada since early 2017 when he participated in our press release that ultimately led to the Fairchild TV special. And Dr. Dahdah is also on Kawasaki Disease Canada's Advisory Council. So thank you very much both for joining me. So as mentioned, we'd like to break this session into three parts, starting with education for the general public. So maybe I'll turn it to you first, Dr. McCrindle. So really, what is Kawasaki disease, and is it known by any other terms?
So Kawasaki disease was first described in the 1960s by Dr. Kawasaki. And at that time, I think it took on the name of mucocutaneous lymph node syndrome. And it also got some confusion with another disease called polyarteritis nodosa. And it wasn't until Dr. Kawasaki described the first case series that it started to take the name of Dr. Kawasaki. So Kawasaki disease is a clinical syndrome of it's a spectrum of symptoms and signs that very young children can get, which include red eyes, red hands and feet, swollen lymph nodes, rash, and oral changes in the mouth and the lips, but and also associated with high fever. Most kids who get Kawasaki disease, even if they aren't treated, it resolves with spontaneously and without any particular complications. However, about 25% of kids develop inflammation in the arteries of the body, particularly the coronary arteries, which supply the heart itself with blood, that cause the arteries to become weakened and then develop what we call aneurysms. And that's the major complication of Kawasaki disease. However, with the rapid treatment in the early stages of the illness with something called intravenous immune globulin, that the likelihood of developing an aneurysm falls to 4%. So we're able to prevent aneurysms, but not prevent them completely. And probably some kids actually have aneurysms at the time of the diagnosis. Right now, we don't know what the cause of Kawasaki disease is, but it's felt that certain kids who may have a genetic predisposition to develop an inflammatory problem, when they're exposed to a certain either infectious or environmental trigger, have this immune response to it that starts to attack their own bodies. And that's exactly what happens with Kawasaki disease.
Great. Thank you very much, Dr. McCrindle. Dr. Dahdah, how does a healthcare professional then determine if a child has Kawasaki disease? How is the diagnosis made? I think you're on mute, Dr. Dahdah.
Yeah,
Sorry.
thank you for the
Yeah.
question. Following your introduction in terms of awareness to the general public, I think part of the diagnosis comes also from the from families and neighbors and grandmas and aunts and uncles knowing about that this entity does exist. Um, what's very important is a constellation of symptoms that Brian just mentioned that we have to keep in mind. So typically kids come with high-grade fever and it persists more than 4 or 5 days. The typical viral infection doesn't last more than 5 days typically. So anytime a fever lasts more than 4 to 5 days, then we have to start thinking whether or not the child has Kawasaki disease, especially if they do have other symptoms. And I will call the fever crash, C for conjunctivitis, R for rash or skin rash, A for adenopathy, S for stomatitis, and H for hands and feet. So I repeat those. Fever crash. So kids do have, besides this high-grade fever, they do present with conjunctivitis. Both eyes are red. They don't have secretions in the eyes, but are bloodshot injected by vasculitis. And then skin rash could be anywhere on the skin from head to toe. It doesn't have to be everywhere, but it could be everywhere. Typically, there are no vesicles. There are no pimples there with fluid inside them. They're just redness of the skin. The adenopathy is the big swallowing of lymph nodes in the neck. Usually it's on one side. It could be both sides. Usually we can see them. And sometimes they become very, very large and they could be compromising. And the S in the crash is for stomatitis, which means the stoma or the mouth gets swollen, red, cracked lips, sometimes some bleeding on the lips. The tongue becomes very white in the beginning, and then the tongue becomes very red, like a strawberry. And finally, the hand and feet. This is where the hands and the feet or the feet of children, especially the young ones, become swollen, and the soles and palms become red. So I think if I have to repeat it without details, any child with high-grade fever without obvious explanation, like big symptoms of flu or big gastroenteritis, with those constellations of symptoms, I repeat, conjunctivitis, the skin rash, the adenopathy, the stomatitis, and hands and feet swollen and red, should trigger people to go and ask their doctor whether or not their kid has a known disease, just to start with.
Okay.
Now, I mentioned all these symptoms, but they don't all have to be present at the same time.
That was going to be my next question, right? So thank you, Dr. Dahdah. So Dr. McCrindle, if they don't show up, I mean, certainly if you had a child that had all of those, a parent would know there's something wrong if all of those things are happening. But as Dr. Dahdah says, it doesn't necessarily happen all at once. So what are some, how do they appear? Do they appear, every few days, or how do the symptoms appear?
Yeah, so the symptoms can appear at various times. In a patient who has complete Kawasaki disease, they will have all of the symptoms, and usually at some point they'll have them all at the same time. Infants, however, very, very young children are more likely to have what we call incomplete Kawasaki disease, where they have maybe only 2 or 3 of those signs. But the way the diagnosis then gets made is we have a number of lab tests that we can do that provide additional information and additional clues that help us to make the diagnosis. One of the things we also can do is do an echocardiogram. And if we see any abnormalities with the coronary arteries, then that sort of clinches the diagnosis of Kawasaki disease.
Okay, great. We recently had a conversation with a couple of researchers that are looking at a diagnostic tool, and I know there's a number of groups that are looking at that. So this is for either Dr. McCrindle or Dr. Dahdah. Are you hopeful that a diagnostic tool could help make earlier diagnosis of Kawasaki disease? You muted yourself, Dr. McCrindle, sorry.
Oh, sorry. I'm not
That's
sure
right.
that a diagnostic tool would be that useful because the symptoms and signs and the lab abnormalities are rather non-specific and can occur in a whole number of illnesses that are much, much more common than Kawasaki disease. However, you know, what would be more important if you wanted to make an earlier diagnosis is for both families, but in particular healthcare providers, to be aware and even though Kawasaki disease is rare, unless you think of it, you're not going to make the diagnosis. And I think putting that foremost in the minds of clinicians is really what's going to help to make the diagnosis earlier.
Great, thank you. Dr. Dahdah, anything you'd add to that, or shall we move on?
I think when we talk about tools, there are some development on the various labs that Brian mentioned that are standard labs results. Some people put those in a calculator that will give you higher index of suspicion. But again, I would repeat that the index of suspicion from the clinical presentations and the symptoms should be the trigger. And we leave this typically to physicians to put things together.
Okay, thank you. So we know that at this point there is no cure for Kawasaki disease, primarily because we also don't know what causes the disease. We know too that the treatment for Kawasaki disease is primarily intravenous immunoglobulin, or IVIG for short. So let's discuss what else we know about the disease. First, something that's top of mind for people right now, of course, is COVID-19 and how highly contagious it is. Is Kawasaki disease contagious? Can it be transmitted from person to person? Dr. Dahdah?
Typically, no. In other words, if it were a contagious disease, we would have immediately withdrawn any kids from daycare or from school anytime they contract the disease. What we know is that when it happens in one child, it could occur in family, in brothers or sisters, basically because of the predisposition, genetically speaking. But in terms of I get KD and then my next door or my my friend at school will get it, the answer is no. It is not contagious.
Okay, thank you. Dr. McCrindle, you mentioned that Kawasaki disease does have a genetic component to it. And we've also heard sometimes siblings getting it. So if it's not contagious, that would, not be the reason why a sibling is getting Kawasaki disease as well. So would it be because of the genetic components, or are there predispositions to developing Kawasaki disease?
Yeah, so you know, considering Kawasaki disease as a contagious illness is probably not true because we don't know what the cause of Kawasaki disease is, and it's likely that there are many different things that can trigger this immune response that gets manifested as Kawasaki disease, and they could be infections, and sometimes infections can actually be one of the factors that may predispose you to react to whatever the trigger is for Kawasaki disease. You know, there's been lots of work that have talked about environmental triggers, you know, particularly things that may be blowing in the wind, in the high atmospheric winds over Mongolia. So there are many, so it's highly unlikely that Kawasaki disease is rare, and it's rare for family members to get Kawasaki disease. So being a family member, you do share some genetic background, and it does increase the likelihood that another child in the family may get Kawasaki disease. But you're talking about a rare disease that's still rare. So it's rare. You're upping the risk, but not in any perceptible way.
Okay, thank you. We know that IVIG is the treatment. So Dr. Dahdah, are there any adverse reactions to the IVIG therapy for Kawasaki disease? And if the patient doesn't respond to IVIG, are there any alternatives?
Excellent question, because we have to start saying that there are no major or no frequent adverse events to IVIG. Let's get it from the start to make it clear. Now, yeah, of course, some children do react in a different way to IVIG. Some children, it is well reported that some kids would have signs of meningismus, which is signs of inflammation in the cerebrospinal fluid without meningitis itself, but they do represent such symptoms. Some kids have very high fever and chills as a reaction to IVIG, and they need pre-preparation with corticosteroids or other medication. One other side effect as well, and all these side effects are practically rare, is hematuria. Probably due to sorts of IVIG, not all brands, but some sorts of IVIG have been associated with hematuria, which is blood in the urine. And all these symptoms and side effects are easily resolved, easily treated. But there is no reason not to give IVIG in general. And it is actually a life-saving, since, as Brian said in the beginning, instead of one child out of 3 would end up with aneurysms of the coronary arteries, given IVIG reduces the risk much lower than that.
Okay.
So yeah, I mean, the second part of the answer of the question is whether or not all children would respond to IVIG. Unfortunately, the answer is no. So there are sets of cases of patients, about 20% overall, 15 to 20% of children who do not respond well to IVIG, and they maintain fever, they maintain inflammatory signs in the blood. They require a secondary therapy.
Okay, thank you. Why don't we kick off the section of education for families or patients of Kawasaki disease? And we can do that with a question actually from the audience. And this is from Merrill. It says, my son has aneurysms from having had Kawasaki disease and is on 81 milligrams of aspirin each day. Will he have any negative effects from the aspirin long term? Dr. McCrindle?
Yeah, so the answer to that is no. You know, some of the medications that a patient with aneurysms may be on may be associated with some long-term consequences, but aspirin isn't one of them. The other thing with the aspirin is people often worry about the possibility of developing Reye's syndrome, which is a severe life-threatening illness that sometimes is associated when a patient either gets chicken pox is the most common trigger for that, or other types of viral illnesses. And as far as I know, I don't know of a case of a child developing Reye's syndrome who's only on low dose aspirin. So now, with regards to other medications that a patient with aneurysm might be on, warfarin is associated with some loss of bone mineral density. And it is something that when we follow our patients on warfarin or Coumadin, that's one of the things that our hematology experts monitor the children for.
Okay, interesting. Thank you so much. So some more questions. We often hear from parents whose children are experiencing various issues after having had Kawasaki disease. And the question is always, you know, is this just another thing, or is this because it's related to having had Kawasaki disease? And I know sometimes it's hard to sort through that. So we have a few questions that have come in as we support families, and I'm just going to go through a couple of them. And please feel free to jump in to see who wants to go. So this one is around depression. So can Kawasaki disease cause depression, and can it affect the mood of the child that had previously had Kawasaki disease?
Yeah, there's no long-term issue after Kawasaki disease of having mental health issues. During the acute stages of the illness, the infants can be very irritable, and that can last for a couple of weeks after the illness has resolved. but there's no long-term sequela from that.
Thank you.
Yeah, I would say the same thing. There are no known long-term sequelae. There's a large series on other mental illness of concern for families. It has been tested in a large series in Korea, and this is and it has been shown that to be no actual or significantly association between Kawasaki disease and long-term learning problems or autism.
Okay,
Yeah, I
thank
have
you.
to add a qualifier to that, and that's that children who have ongoing cardiac issues after Kawasaki disease can sometimes develop, and it's not related to having had Kawasaki disease. It's just being having this illness hanging over your head can develop problems with anxiety, and that may be a scenario where a child may develop depression in having to cope with this chronic illness
Okay,
and the
yeah,
uncertainty that goes with it.
very good. Thank you. Can a child who has had Kawasaki disease contract it again in the future?
Rare. What
Rare.
the way
Rare.
I answer families to this question is, the farther you are from the acute illness, the less likely to have inflammation of Kawasaki disease again. So the first few days, first few weeks, maybe so, and then next couple of months, even less, much less. And we've seen kids who have had Kawasaki disease almost typical or so 1 or 2 years later. But anytime it's more than second time, I would go to search for another illness with rheumatology and immunology. So recurrent and relapsing for whatever, it's almost no, I would say that. Ryan?
Okay.
Yeah, I would agree with that the patients that I've been involved with who had later recurrences of what was thought to be Kawasaki disease, eventually coughed up a different diagnosis. And one of the most common, in that particular scenario, rheumatoid arthritis comes up.
Interesting. Okay, thank you. Just a reminder to our participants that if you do have any questions for Dr. McCrindle or Dr. Dahdah, please type them in the Q&A and we'll get to them through the session. I do have another question though that did come up sort of prior to the session. It was sent in to us. So if a child does not have any coronary involvement or has involvement that ends up being resolved after the acute phase, should they still be followed by a cardiologist periodically?
Yeah,
Quick answer. Go ahead, Mr.
So I can
AHA.
answer that one.
Yeah.
So children who have had Kawasaki disease and had no evidence of any heart involvement, or who had dilatation, not aneurysms of the coronaries, but just a little bit of dilatation that resolved within a couple of months, we know that they're at risk for nothing in the long term. And so we actually discharge those patients with no further follow-up. However, I always tell the families that even though there are no sequelae whatsoever, that having had Kawasaki disease now becomes part of their child's medical history, such that if someone ever said, did your child have any illnesses as a child, you would say, yes, they had Kawasaki disease, but they had absolutely no complications and were discharged.
Okay, thank you.
Now, the aneurysm patients are a different group, and I'll let Nagib talk to that.
Actually, it is the problem from Kawasaki disease. Developing coronary artery aneurysms underlines that these patients are at risk of getting problems with their coronary arteries. If the aneurysm is very, very large, very big, and they are not on proper medication like blood thinners like heparin or coumadin warfarin, they might be at risk to develop clots in their coronary arteries. And this is potentially a life-threatening event of ischemia, heart attack. Some children also, due to the sub-inflammatory process in the aneurysms, end up with stenosis, scarring, calcification of the vessels, and they narrow down, and they are also at risk of heart attack due to these complications. So these patients are truly those who need regular follow-up in cardiology.
Yeah, and I would just add that, our own data that we collected on close to 2,000 aneurysm patients with the International Kawasaki Disease Registry really showed that only those patients who had very large or giant aneurysms were really at risk for developing heart-related events or things like heart attacks or clots or stenoses in the medium term. We don't know what the kids with the small aneurysms or the medium aneurysms are going to do in the ultra long term, but I think that this preliminary information should be reassuring to them.
Great, thank you so much. And I know that Kawasaki Disease Canada is actually helping to fund some research that a rheumatologist, Dr. Michelle Batiche at McMaster Hospital is doing around, as you say, the longer term outcomes for children that have had some involvement early on. So similar to what the other parent asked, is there any research that provides this question is actually what we think we just talked about, which was around provides information on the long-term cardiovascular health of patients. So maybe I'll tweak the question a little bit and just say, what are the signs that an adult has had undiagnosed Kawasaki disease? So if Kawasaki disease went undiagnosed, are there things that are seen in adults? What would be the signal that adult perhaps had Kawasaki disease when they were younger? If it didn't go with them as part of their medical history, or if it went undiagnosed.
Yeah, there are adults that develop sort of premature or heart disease at a young age that will actually present with an acute event, which could be a heart attack, and sometimes it's not always clear if you dig back in the past history whether they actually had an episode of Kawasaki disease or not. But when they're investigated and the coronaries are looked at, they can have changes that are really consistent with the changes that you see in someone who's had aneurysms that were a complication of Kawasaki disease. It's a small group, but it is a reason why we feel that adult cardiologists should also be aware of Kawasaki disease and how to manage it, particularly when these unexpected events crop up.
Well, that's interesting. And maybe we actually transition into that part around education of healthcare professionals, and then we'll circle back to some other questions that the families had. But with regards to education of healthcare professionals, other cardiologists, like you mentioned, adult cardiologists. So what are some examples of things that you both do to promote education of Kawasaki disease for other healthcare professionals? So I know Dr. McCrindle, for instance, you had a PhD student for some time as well that you were helping bring her along with the knowledge of Kawasaki disease. I know that both of you have participated in research, but what are some other things that you do to get the word out about Kawasaki disease to your colleagues? Maybe we'll start with you, Dr. Dahdah.
Exactly. This problem is worldwide, including in Japan, where the epicenter of Kawasaki disease. In the last meeting, international meeting of KD, 2 years ago or so, one parent came talking about this problem where physicians don't really actually know where to transfer the young patients who become adults, which specialty, which subspecialty, which group of adult cardiology, because the two illnesses, that is Kawasaki disease with coronary artery aneurysms, is different from the typical atherosclerosis, and that is coronary artery disease in the adult. So it is a worldwide problem, including the epicenter where Kawasaki disease is very well known, broadly known in Japan. So for many years, Brian, myself, and most of our colleagues are trying to push the information to almost breaking arms of our adult cardiology colleagues to take grasp of the illness as a science, not just as one patient came to my clinic, was transferred to me. Only lately we had a paper that should be in circulation sometime soon. It's an awareness paper from American Heart Association, where we are seeing this point of need for transfer of care. It doesn't only involve transferring a patient, but teaching people, teaching new adult cardiology fellows, new interventionists of these two differences between the two illnesses. So it always starts and ends with information and learning. And this is an effort we need to keep on.
Great, thank you. Dr. McCrindle, anything you'd add to that?
Well, yes. So I would have to say that a lot more physicians are aware of Kawasaki disease now because, early in the COVID pandemic, Kawasaki disease and COVID were starting to be said in the same sentence with regards to an inflammatory syndrome associated with COVID in children that had a lot of similarities with Kawasaki disease. And so I think awareness amongst the healthcare community and the public about Kawasaki disease has increased sort of accidentally because of that association. I know both Nagib and I have served on the American Heart Association committee called Rheumatic Fever, Endocarditis, and Kawasaki Disease. And while I served on the committee, I was the lead person organizing the latest iteration of the Kawasaki disease diagnosis and treatment guidelines. And Nagib has just mentioned that he's been advocating for appropriate transition of these pediatric patients into adult care. Both Nagib and I'm sure, are always giving talks about Kawasaki disease. And whenever I'm asked to go travel or invited to be a visiting professor somewhere, invariably the topic that I'm talking about is Kawasaki disease, including recently international rounds that I gave to the cardiologists who do adult congenital heart disease. I talked to them about Kawasaki disease, and I think a lot of adult programs are now starting to develop a bit of a cardiac Kawasaki disease expertise within their congenital heart disease programs. Another thing is that now that everybody is online all the time, I think it really increases the amount of communication that's been going on. And there's been a lot of webinars about Kawasaki disease. And indeed, one of our goals with the International Kawasaki Disease Registry is to provide communication and education. And we've had 4 open webinars that were open to broadly the physician community about different aspects that are related to Kawasaki disease. So, I think both Nagib and I have been strong advocates for education, both within our own institutions and communities, but also nationally in Canada and internationally.
Excellent. And what you said about the COVID and increased awareness, I call that a little bit of a COVID silver lining that, unfortunately it took a pandemic, but we are seeing increased awareness, as you say, both with the public and healthcare professionals. So we've been presenting education sessions to pharmacy students for years. We've done some training with the emergency room doctors and nurses and other groups. So any other advice you would have for Kawasaki Disease Canada and how we can help further the work that you do around education? Or is there something that you could see us being able to do? Maybe I'll turn that to Dr. McCrindle first and then to Dr. Dahdah.
So it is important. It's just a trend that's been happening over the last 10 years to have, for clinicians to have greater stakeholder engagement So actual engagement that goes both ways, where the actual affected patient community has direct input into the things that are important to them, the things that we should be looking at, the things that we should be doing to advocate uh, for better care and better awareness. So I think that is been one of our goals, is trying to engage more organizations like KD Canada and in the US, the KD Foundation.
Mhm. Thank you. Dr.
Yeah, I
Dahdah?
would add to that that within the International KD Registry, the IKDR, as you said in the beginning, it was North American. Now it's actually international. And it does make a difference, not just for research, not just for gathering data, but also when we hold the webinars, when we engage people from all across. I mean, the national interest in those countries will increase, and every single person who's attending the webinars or collaborating with the IKDR as a researcher would become an attraction, a local attraction, as an expert or as a knowledgeable person. And this is a very, very important point. The last 2 weeks I spent with different institutions in Arab countries where the disease has become to be known in the last 5 to 6 years or even less, progressively. And now the interest is really huge. It's really very important. And we're trying to draw these individuals and institutions towards the IKDR. There are efforts also in South America, in Asia, Eastern Asia, and Southern Asia. It almost always takes one person to trigger and to push the information around oneself, and this is from word of mouth. It becomes a trend, and a very social and well-known subject.
Mm, interesting. Yeah, we collaborate with some groups in primarily in Europe, but also in Australia. The next session that we have actually on Kawasaki Disease Awareness Day on January 26th, we'll have a panel of those groups like ourselves in other countries and talk about some things that we do perhaps differently than what they do in the UK or in Spain or in Italy. But you're right. I mean, it just, we need to continue to have these conversations. And so, you have our commitment that Kawasaki Disease Canada will continue to do our part to help spread awareness and education. There's a comment in the chat that is around the transition plan from when a child, was with one of individuals like yourself, very knowledgeable pediatric cardiologists who know a lot about Kawasaki disease. And then when they transition to an adult cardiologist, what does that transition plan look like? And where are there some opportunities to perhaps help educate the adult cardiologists in that transition plan? Dr. McCrindle, do you want to jump in with that?
Yeah, so the most important thing about transition is, first of all, having a destination. And it's taken some time for us to get an adequate destination for our patients in Toronto to go to. And it's become particularly challenging recently in that the person that we'd invested in has moved on to another institution. But the good news is that a new person has taken over this population, and Dr. Sarah Thorne, and she's really excellent. And she also happens to have a strong interest in transition. And this is all happening at the same time, that as we're developing a new person on the adult side, that a whole transition program is now getting developed here within our heart center. So we have a cardiologist and a nurse who's taken this on. They've partnered with equivalent people across the street so that hopefully in the future, we'll have better education for the patients before they go across the street. But to tell you the truth, you do have to prepare families that, you know, it's a lot different in the adult world. They may not see the patients as frequently. They're going to talk to the patient and not to the parents. They expect you, the patients, to know all their medications and know why they're on those medications, to know what sort of things that they may be possible in their futures. And I always tell the kids as they go across, it's a different place over there. There's no clowns wandering down the hallways. You're expected to be an adult, and you're going to be treated as adult. And you know, here at Sick Kids, if you miss an appointment, we're going to get on you, and we're going to track you down, and we'll make sure that you show up. You miss an appointment in an adult facility, that's not going to happen. The onus will be completely on you to rebook that appointment. And so sometimes, you know, that transition can be a little bit hard to deal with. But, you know, one of the elements that we're working on in our transition program is to help kids to develop these skills, these self-advocacy and these educational skills, so that they're already in place and they know how to use them when they actually have to use them when they go to the adult facility.
Yeah, that'll be very worthwhile. And you mentioned about like both of you, you know, Dr. McCrindle and Dr. Dahdah are in major centers, so Toronto and Montreal respectively. And you know, we hear from families from coast to coast to coast. And I'm just wondering, what types of calls do you get from other physicians across the country, and sort of what types of consultations are you pulled into, and at what stage? Like, when would you be involved? Would someone call you from the Northwest Territories, for instance, knowing that both of you are well known in the KD world? Dr. Dahdah, any examples of when you called in for consultations and what that looks like?
Oh yeah, absolutely. Already in the city of Montreal or in Quebec province overall, I do receive on occasions calls about an adult with potential acute Kawasaki disease, which again, it is rare, much rarer than the pediatric cases. On occasions also, I receive calls about what to do with this young adult who had Kawasaki disease in the past. So I think besides the transition, there's also the bridge. Don't we keep the bridges always open both ways? To and from between the receiving institution or receiving colleague. Decision making has always been still up to date, always been bipartite between myself, my colleagues in pediatric cardiology and the adult cardiology. But what's funny is when you ask about consultations from away from Montreal, people find me typically for French information, because French educated at the same time. Sainte-Justine is also the French part of the city. So I do get calls or emails from North Africa, from Europe, from North, South America, from families, expats who speak French and need information. So I think the channels are always open, and this is a different way of bridging out to and from patients. Funny enough, sometimes patients would tell another family, well, you can speak to Dr. Dahdah in Montreal. And yeah, I do. Sometimes I reply in the middle of the night because I can't keep it silent. I know how anxious parents could be.
We try not to do that too much. We try not to say, you can call Dr. McCrindle or Dr. Dahdah. So Dr. McCrindle, other than reputation and word of mouth, how do other healthcare professionals find you? Is it you know, like they Google and find that Dr. Brian McCrindle has presented some, you know, some talks or some research, or is there a place? Is there a registry or something, not the IKDS registry, but another registry where people would know, if I have a question about Kawasaki disease, these are the people I could call?
Yeah, there is no registry, but you know, since I was the lead author on the guidelines, that's how a lot of people get to me.
Right.
You know, in Canada, the pediatric cardiology community is small. I think I could probably name to you every single member who's a pediatric cardiologist in Canada. And so they all know that because I've spoken to them and I've written about Kawasaki disease, that they can contact me with a clinical question. And so I do get a lot of questions about patients. Usually the questions I get asked are patients that are very, very complicated, both in terms of their acute management, but also in terms of having terrible cardiac complications. It does get a bit challenging when I'm approached directly by a parent, because I can't give medical legally. It's hard for me. I can't give advice specific to a patient that isn't my patient. But I do tend to give general advice or speak generally around the topic. But I also encourage them to reach out to their own healthcare providers. And if their healthcare providers have questions or are uncertain about something, then they can reach out to me directly. Sometimes I do wind up getting some second opinions where I actually wind up seeing the patient themselves.
Okay, interesting, yes. Back to some questions that we got from parents. And you kind of answered this, both of you, earlier when you said there sort of are no other issues for children who don't have a coronary involvement. However, many parents have noted that their children have ongoing joint pain for years after their original incident of Kawasaki disease. Are you aware if there's any research linking Kawasaki disease to long-term joint issues? Dr. Dahdah, you're leaning in. You're on mute still. There
So
you go.
yeah, I'm not a rheumatologist, so I won't answer directly to that question. But I can tell you that I follow these kids, even with mild illnesses and no complications. I follow them a good year very often. Sometimes I offer families to come back within 5 years at their ease. Anytime I see symptoms or signs that could be related to rheumatology, I would ask rheumatologists for consultation. Psoriasis is one thing. Rheumatoid arthritis is another thing. I've seen a kid who had supposedly recurrent KD fever, or whatever you want to name it, and ended up with myositis, which is another autoimmune disease. So I don't think that kids with Kawasaki disease would have joint problems that are only related to KD itself, but probably to the genetic background of the patient, and they should consult with a rheumatologist, in my opinion.
Thank you. Dr. McCrindle, anything you'd add there? I know that certainly at Sick Kids, patients that come in for follow-up are seen by both a pediatric cardiologist and a rheumatologist. Is that the case everywhere? Would most hospitals or most settings have a child followed by both a pediatric cardiologist and a rheumatologist?
Yeah, so things are different at every single institution. So, for example, in some institution, it's the general pediatricians that take the lead. In others, it could be the infectious disease specialists. In others, it could be the rheumatologists. Not so often is it going to be the cardiologists. The cardiologists definitely are the people that do the long-term follow-ups of anybody that has cardiac complications. At Sick Kids, we have sort of, when a kid is in hospital, when a child is in the hospital, they're really followed by, managed by general pediatrics with the rheumatology and consultation. And cardiology would only get involved if there was any cardiac concerns. However, as soon as the patient is discharged, we see them acutely in the clinic, in a joint multidisciplinary clinic that includes rheumatology and cardiology. But then after that, they're strictly followed by cardiology.
Okay,
So, but like every center is probably a bit different.
right. Okay, thank you. So just a last few-minute warning there for our participants. If you have any last questions, please put them in the Q&A. So I'm going to ask both of you to weigh in on this last question, and then after that, open it up just for one word of advice you would give, or one piece of wisdom, something that we haven't asked you that you'd like to share. So this last question is, another disease recently noted to have almost identical signs and symptoms to Kawasaki disease that we discussed earlier has been linked to COVID-19. The Center for Disease Control and Prevention, of course, has named the disease in May of this year, May of 2020, multi-system inflammatory syndrome in children, or MISC. Are you able to share with us any more about this and any new developments of linkages to Kawasaki disease?
Yeah, so I mean, this is an area of very active research, particularly since a lot of research about other things has had to take a second state base to anything that's COVID related. So it's hard to know whether what we call MIS-C, this multi-system inflammatory syndrome associated with COVID, whether it's a form of Kawasaki disease or whether it's just taking advantage of some of the same disease pathways that Kawasaki disease takes advantage of. It also could be that that this MIS-C is actually Kawasaki disease, where we have only one cause, and that's the COVID virus. But people are doing lots of research to look at particularly the immunology of both of the conditions, to see if there's any similarities and differences that may suggest, some shared pathways in the cause of these two conditions. Fortunately, this MIS-C is rare. That only, just like Kawasaki disease, only a small proportion of kids who have COVID will actually develop this syndrome.
Thank you.
I think it's an opportunity to understand more about Kawasaki disease, since there are some patterns between the two syndromes or illnesses, where Kawasaki disease is thought to be triggered by an illness, febrile, viral or non-viral illness that triggers the onset of the disease few weeks, several days later. And the MISC also seems to be to take on several weeks, 3 to 6 weeks after the child is exposed to COVID-19 or the SARS-CoV-2. So it is an opportunity to learn about both diseases. Probably since KD is long lasting, it's about 55, 60 years old, at least as we know of. And hopefully COVID-19 will fade away, but it would be a good way to learn about the illness that we are dealing with now. Great,
thank you both for that. So I asked, as they say, ask and ye shall receive. So I have one last question from a parent. When would an aneurysm be fixed per se? So what needs to happen before it's decided that something other than blood thinners needs to be done? And then what are some procedures that have had to be done in previous patients with aneurysms? Brian, Dr. McCrindle, over to you for that one.
So I would have to say that the larger the aneurysm, the less likely we would ever use the term fixed. An aneurysm over time can get smaller in size, but that doesn't mean that the vessel is getting to be normal. It's a very complex sort of scarring process that happens by which these aneurysms may decrease in size, that sometimes can progress to the point where they decrease the size of the aneurysms to the point where they start developing narrowings. And that's one of the things that we're always monitoring for patients in the long term, who've had aneurysms. That's not true of the patients who've had no coronary involvement or dilatation only. They don't have that same kind of scarring. Some of the procedures, well, I'll actually let Dr. Dahdah talk about procedures.
Thanks, Brian. Yeah, so procedures are two arms. One arm is the surgical procedure when we have to do a CABG or a bypass graft. It's similar to an adult who would have myocardial infarction or stenosis of the coronary artery. Then we need to reperfuse the muscle of the heart with implanting an artery where we could feed the region that is missing perfusion due to the stenosis. The other arm is percutaneous, or using catheters, where we could go through the arteries and the veins from actually if the artery from the groin or from the hand, and again insert the balloon, dilate the stenosis, put a stent, and so forth. Overall, the surgical intervention has much better outcome, longer better outcome. But both procedures could be indicated for cases for patients who have significant stenosis.
Thank you. Of course, I do have now 2 more questions. Can we take 2 last minutes? Can I keep you both for 2 more minutes? Just briefly then, 2 questions that have just come in. My child has Kawasaki disease, or got Kawasaki disease a few years ago. He has a small aneurysm. We live in Quebec, and kids must return to school this week. Could he be more at risk if he gets COVID? I'm scared. What do you suggest to keep my child at home? So Dr. Dahdah, I'll let you answer that one, and then I'll turn the next question to Dr. McCrindle.
Go to school. We don't think that this young man or young girl is at risk. Only kids who have severe myocardial dysfunction from whatever reason are considered to be at risk. Your child does not have higher risk to contract COVID or Kawasaki disease again, or to worsen the coronary artery aneurysm. Go to school.
Okay, thank you. Dr. McCrindle, with regards to patients that have been discharged from cardiology but experience chest pain or shortness of breath later on, would referral back to a cardiologist be warranted? You're on mute. Sorry. Yeah.
Yeah, I would say that this happens to me a lot.
Okay.
That I can say that of all the kids that have been who I've discharged who came back with these symptoms, they did not have a cardiac issue. And their chest pain was usually related to something not cardiac and not serious, and tended to resolve very quickly and not recur. The same is true of shortness of breath. So I would say that if the patient's been discharged, yeah, sure, they can come back, and it would be reasonable to get a cardiac assessment, but you'll probably just get reassurance.
Okay, thank you. Good advice there. Before we wrap up, any last words, something that you thought I was going to ask that I didn't? It's a question that you get periodically from patients, or some pearl of wisdom that you'd like to share before we close. Dr. Dahdah, to you first, please.
Vaccines. Kids can get and should get their vaccines after the acute illness, after I've received IVIG. In the very young, the live vaccine may not be efficient. They not take and become immune, so they might be postponed. That's the only thing. But there's no contraindication for vaccines, so please get them done.
Including the COVID-19 vaccine?
I mean, if Dr. Fauci says it's safe, we should take it.
Okay, thank you, Dr. Dahdah. Dr. McCrindle?
Yeah, I would take any vaccine that's offered to me, to tell you the truth. And the other thing is that people have asked the question whether certain vaccinations predispose you to developing Kawasaki disease, and the answer, that's been well looked at, and the answer is no. So there's no association between Kawasaki disease and vaccination.
Great. Well, thank you. A huge thank you to both you, Dr. Brian McCrindle, Dr. Nagib Dahdah. We appreciate at Kawasaki Disease Canada you being on our advisory council immensely. And I know our audience really enjoyed this session. Your dedication, your work, your research are invaluable as we move forward in the quest to increase the number of early diagnosis, thereby decreasing the incidence of long-term complications. It helps families and patients prevail over this potentially life-threatening disease. So thank you very much.
Great.
And to our audience, as mentioned, this is the second in our series of webinars called The Heart of the Matter. And I'm just going to share on the screen. I'm not going to share on the screen because I'm not the host anymore. Little glitch with our Zoom system today. But the next session is on January 26th. That's Kawasaki Disease Awareness Day at 1 p.m. Please check out our website and our social media for details on how to register for that session. It's sure to be an engaging one as well as we talk about how to raise awareness. So again, thank you all for joining, and everyone have a great day and stay well. Thank you.
Thank you for hosting.
Thank you. Bye-bye.